All right, good morning, everyone. Thank you for joining us today for today's breakout session on leveraging telehealth to address social determinants in the FQHC environment. My name is Ray Dizon. I'm the project coordinator for the National Consortium of Telehealth Resource Centers, and I'll be moderating today's session. Just a few reminders, your audio and your video have been turned off. And if you want to ask questions, we do advise that you use the Event Mobi app to submit your questions. There's also a nice little feature where you can upvote questions that you're interested in having answered if they're similar to your own. So I'm going to go ahead and introduce our speaker. Today we're going to have Christina Quinlan, founder of the Christina Rose Consulting Group. And Christina, you can take it away.
Hi, it's so good to be here. This is such an interesting concept, right? But I guess it works. If we're going to have a, technology conference, we're using technology, which is great. Are we going to bring up the slides right away, Ray?
I'm sorry, you say that one more time?
Do we have the slides up?
Yes, they are up. Do you not see it?
I do not see it. Hold on, Now I got it. Perfect.
There we go.
All right, let's get right into it. So we're going to talk today about leveraging telehealth to address social determinants or to reduce social determinants of health in the FQHC environment. But this isn't, of course, just in the FQHC environment. It's rural health centers, hospital organizations, community organizations. As we start to advance technology and use innovative tools to advance technology, I think the drive to integrate social care into healthcare is more prevalent as we move towards value-based medicine. Next slide, please. So we can go to the next slide. We can share the slides after so they can do it. So here, when we talk about telehealth to reduce social determinants of health, I always say, okay, we start here, right? Where do we start? Social determinants of health seems so big and broad. We use the term all the time. We see it with HRSA, community partners, sort of goes hand in hand with disparities. So what we did, right? So again, I'm a consultant. I work with many health centers across the state of Maine, in New England, but I'm also the director of operations at a health center on an island off the coast of Maine, 16 miles. So when we say, like, what would you do if you were on an island? Basically, I think the reason why our health center has been so innovative and we have been successful in reducing social determinants and also integrating social care in the healthcare setting is because of our geographical location, right? We did it out of necessity. And now during COVID-19, the big push, everybody sort of did it out of necessity and we're all using it. We broke the barrier. It was a little sloppy. We got to peel back the layers, but we're here. So the first thing that we did, of course, is through community and patient needs surveys, we identified patients who would benefit from telehealth services, right? So patients who identify transportation, as a barrier to accessing care, older adults with limited mobility, but also lack of insurance. So when you think of lack of insurance in telehealth services, I'm a little bit of the old school. We started doing telehealth about 10 years ago on the island. We had a little boat. It went in the middle of the water to all of the neighborhood islands, and we started telehealth services on the Sunbeam. A nurse was there, and our providers were able to treat and see chronic care patients. So we've been doing this for a while. When I say lack of insurance, I think of telehealth old school, which I guess now we would say telecommunications is the old telehealth terminology. Telehealth being that umbrella, right? And then we have like the umbrella of technology. So when I say lack of insurance, we're using our outreach coordinators and our navigators to have those engagements, those outreach encounters through Zoom. And it's worked well for us because we're able to control their screen too. So instead of, saying, hey, click here, we're able to do that for them. We're also able to list ourselves as a navigator for future questions during that enrollment process. We're going to improve access, right? And the effect and the value of healthcare services. Because we're allowing patients also to be treating in their home. We're allowing them to be treated in places where they're most comfortable, in the most comfortable setting. We've been doing that for a long time. I think even our little health center has more home visits than probably anybody else. Chronic care management among special populations. That's reducing social determinants of health, right? How are we going to target those people, and we're going to talk about that a little more. Some of the tools, some of the ways, and some incident use cases. Providing healthy weight and physical activities counseling. We're doing that via telehealth. Of course, again, in the eligibility and enrollment. So we started sort of there. Next slide. And then the big question, right? Get paid here. So in the beginning, about 10 years ago, there wasn't really a reimbursement strategy for telehealth, especially in a federally qualified health center for Medicare, right? But we always say, oh, FQHCs, they're not allowed to do it. That's not true. If you're looking at your payer mix and pull Medicare out, right? Let's not even think about COVID-19. Let's just think about all of your commercial payers, what state you're in, and if there's parity in payment. And then take a look at your Medicaid program and what state are you in, and is there parity in payment, and can an FQHC be a distant site provider? I can tell you there's, I want to say 42 states that allow FQHCs and RHCs to be distant servicing providers. And I think the latest might be 29 or 30 that are offering parity in payment. So that means you're going to get the same exact payment for telehealth services as you would for services that replace that in-person visit. So that's sort of a no-brainer, right? As far as matching service for service and then the payment. The other thing, like I said, 10 years ago when we didn't have that sort of reimbursement strategy, honestly, I didn't care, right? Because the reimbursement may not always be there, but the value is. So maybe I didn't get the payment that I wanted for that service, but I was getting it in my quality dollars. I'm also now, I feel we're a little further ahead on the leading edge and not bleeding edge of value-based payment, because our patients have sort of been prepared to get these phone calls more. And we can absolutely tie in the reduction of no-show rates, which is another return on investment and value. And then we were also able to reduce the duration of our big visits like wellness visits and physical exams, because we were carving some of those pieces out, which we're gonna talk about. Training your team, right? So our LCSWs, during COVID-19, our registered nurses have always been involved in telehealth services. And our licensed clinical social workers, of course, have been involved as far as like individual psychotherapy, right? But we have school-based health services. And so during the summer, our LCSWs panel decreases. So we utilize our social workers for those expert screenings, the DAS, the auto tobacco cessation, the MCHAT, and the emotional and behavioral health screenings, which are all paid separately, right? And can also be included in a workflow, which we're going to talk about in a little bit. And it would be interesting here if all of you had sort of had my slides and grabbed the 96110 and grabbed the 96127 and the GO447 and the GO444 and said to your revenue cycle management team, how many times have we billed for these services? Well, oftentimes, if you're billing for those services when there's another medical visit, it's not going to be paid. However, any person, what we've been doing is any PHQ-9 that is over 10 is a part of our population. It's a special population, right? And so our behavioral health providers can provide emotional and behavioral health screenings, particularly the PHQ-9, and you can bill at G0444 and FQHCs get paid the PPS rate. If a patient is walking in and you're just setting those screenings to be done annually, you're handing them a piece of paper, they're filling it out, the provider is coming in, they're kind of looking at it, and then they're billing for either their preventative, their wellness, or their office visit, and you're not getting a separate reimbursement for that PHQ-9. So especially with this year, with the changes in UDS, that's a workflow that we're just starting. Especially during this time where telehealth has been so accepting and we're able to do this via telehealth, especially for Medicare patients. But we're also adding, of course, the GAD, and we're also adding the behavior counseling on obesity. And I'm not sure that a lot of health centers are taking advantage of this code. It is listed under your PPS codes. It's 15 minutes of behavioral counseling on obesity, and we're going to treat this just like any other population, especially as it ties into 2 of our UDS measures, right, which is the adolescent weight and BMA, and then the adult weight and BMI assessments. Next slide. So telehealth to fill the critical gaps, right? So here's what we're doing now. We're providing episodic care for low acuity health conditions. We're doing medication adjustment therapy, our SUD services. So again, if you're in Maine, we're a distance site provider. So post-COVID, you're good. Commercial payers, again, you're good. Is there parity in payment? Yes. Well, for SUD services, substance use disorder services, for Medicare, we have been good since July of 2019 because patients can have their originating site be in their home, which means that we can treat patients in their home, Medicare, FQHCs, for substance use disorder services. So that is a population post-COVID for sure that's going to stay in place. So I wanted to make sure I just pointed that out. Follow up to labs, right? Point of care decisions are easily made when labs and vitals have been completed. Turn a telephone call into a telehealth visit. What I mean by that is, we're all sort of prepping or preparing for value-based medicine, right? And so I think about where are we going to be in 2 years? When I look at the HEDIS measures and the NQF measures and the Healthy People 2020 measures, on some of those measures, I could be 20% off. One, because I don't think that those measures are necessarily attainable, especially with some of the health disparities that are going on, the limited access and such, right? So how am I going to get there? So one of the things that we sort of determined, where we have a finite population, which is easier for us, is that we needed to sort of set, we needed to, how do I say it? We started to use evidence-based medicine as the mechanism, right, to determine follow-up care. So instead of it being provider-initiated, which providers get busy, and if you're just relying on a provider to say, yeah, follow up in 30 days, or follow up in 90 days, or follow up in 60 days, we were noticing that there were some gaps in care. So now with our population health manager and our care management team, but also as a practice-wide, everybody knows, if you ask any one of my staff how many times a diabetic patient with a controlled A1C is seen, they would tell you twice a year. If you ask them how many times a diabetic patient would be seen, and this is our front desk, right, because they're our schedulers. What is the scheduling protocol? They would say 4 times. And so basically what we would do is we would schedule the labs and there'd be an automatic 2-week follow-up, right? The worst thing to do for chronic care management is to put a patient in front of a provider without a recent lab, especially when it's for that condition. So when COVID hit, we were worried, are we going to see our chronic care patients at the duration that is not only evidence-based, right? But also what we've seen in our numbers and the improvement in our numbers following this sort of strategy instead of, again, provider-initiated, we're looking this as a whole, and it's the intervals are based on population. So when COVID hit, we said, well, what are we going to do? Like, we don't have labs. We just don't want to schedule chronic care visits just to schedule them, right? Because we had a reduction in services and everyone was scattered. You know, we need the labs. And so what we did is we opened up the labs. So when we did not have, we had a huge reduction in in-person visits, but we could also see these patients outside, which was great. And so during your lab appointment, we got the height, weight, and blood pressure. And then all of those patients now were able to be seen via telehealth, where ordinarily maybe a negative lab would have resulted maybe just in a phone call that said, you know, your labs are good. We're going to go ahead and schedule you in 6 months. No, these labs turned into a full chronic care visit with the recent labs, and then the interval was set based on those labs. So if it was normal, the patient was set to have another labs in 6 months with a telehealth appointment. And then if it was abnormal, it was labs and then 3 months. So that has been working really, really well for us. And it's been a practice-wide, so everybody is aware of those intervals. Again, chronic care management, right? That's how we're doing that, especially with recent labs and vitals. And we have absolutely decreased our no-show rate. So at first I'm like, where's the data? Where am I going to find the data with telehealth? Am I going to be able to do a very clear ROI? Can I make a comparison? I know that the value can be there, but when is the value most valuable, right? And I can kind of talk about that with questions later, because we have certain visits that we prefer to do telehealth and patients prefer, and we have others that we don't. Unless a telehealth visit can have the same value as an in-person visit, we don't do it. Next slide. So the virtual visit algorithm, I just want to touch base a little bit on knowing the difference, because there are 4 types of virtual visits, right? We have our telehealth visits, which used to be called telemed. So your telehealth, oh, we want to go back, right there, yeah. So there are 4 types of virtual visits. You have your telehealth visits, that replaces your in-person visits. You have your e-visits, which are your online E&M visits, your virtual communication, and your telephone E&M. So during COVID-19, it's been a little bit confusing. You guys are going to have the slides. I'm not going to spend a lot of time on this, but I just wanted to tell you that if you look at the definition of those telephone E&M codes, which is your 99441 to 99443 and the 98966 to 98968, you're going to notice that the definition of those look just like VCM services that roll up to the G0071. Post-COVID, it's going to be the G0071 that you use. For now, I would not. I would use your telephone E&M visits, because do you want to get $92.03 or do you want to get $24.76? So that's just the little tooltip for the day. So the next one, next slide, please. Okay, so clinical uses, right? Non-clinical uses, integrating social care back into healthcare. Now we know right now that value-based medicine isn't a matter of if, right? It's a matter of when. Right now we have our ACOs, and they're starting to integrate slowly social care back into the healthcare system. We also know that reducing social determinants of health and health disparities is going to be a major factor in value-based payment. I think it's going to happen to us, and I think that we have to be prepared. And I don't think that it can be done without telehealth. I'm not the only one who doesn't think it. We can do all the resources, all the research, and I can provide more research and resources for you. And I do have a list of them. And as you start researching and looking at some of the incident use cases and case studies, it's going to be clearer and clearer that we're going to have to be doing this, and that that the reimbursement may not always be there, but the value is, and you can be reimbursed. You can diversify sort of a revenue stream based on some of that integration. So again, it might not be visit to visit, but if we're looking at big picture, it's very attractive to integrate social care back into healthcare. The grant opportunities are there, and the value is especially there. So for the first time, sort of, we are starting to we're linking medical and non-medical services in ways that can help the providers meet their bottom line. So it's no longer charity, right? That's what we say before. Well, we can't just give all this charity care away. Well, they're not really calling it charity care anymore. And I think pretty soon, in a couple of years, it's going to be a requirement. So we look at this as sort of getting on that leading edge instead of bleeding edge. I have been through, I don't even know, I can't even count, endless and endless webinars and seminars about value-based medicine. And I walk away thinking, what do you mean? What does this even mean? You know, this is really just quality. And if we don't hit our numbers, we're kind of like screwed. You know, to simplify it, you can go, okay, there's risk, there's non-risk, there's downside. I see the same slides, but basically what is going to happen is there's going to be those national measures. If you don't hit them, you're going to get less than what you would normally. And so that's how I sort of, you know, simplify it. So I say, well, how am I going to get there? I can't imagine getting there without integrating social care back into the healthcare setting. And how do we do that, right? So there's awareness, adjustment, assistance, alignment, and advocacy. I have included the works, right? So integrating social needs care into the delivery of healthcare. Improving the Nation's Health. And you're going to see that that is a great read. It's a mandatory read, and it's sort of like my mantra right now. It's bringing us back into grassroots with payment, which I like, right? Because if there's no money, there's no mission. But I'm feeling like the pull, especially for federally qualified health centers and rural health centers, that we're getting into that grassroots movement more and more, and we're working backwards on that ideology, but we're moving forward on the reimbursement strategy, which is great. So case management. I talk about being on an island, right? It's like, what wouldn't we do? I'm not just on an island that's unbridged. It's an hour and 15 minutes to get to the mainland. There's a single engine Cessna that can be flown for a medevac through a private airport, or we rely on life flight, right? So if we're calling life flight for a patient with abdominal pain, and there's only, say, 2 helicopters, then we're also taking it away from somebody who could be in a major accident. So we had to sort of strategize about what we're going to do, and we do some pretty cool things out there on the island to get people the help that they need when they need it. One of the other things, though, that we started to think about was case management. So to get off the island, and remember, you might not be on an island, but you're in rural Maine or Vermont or any rural sort of environment where there is geographical or logistical challenges to get patient the services that they need, or linking community resources to your patients, right? So we were like, forget it, we're going to have like sort of a telehealth room, and that's the room, and that's what we're going to call it, just like we have a room at the school. And we're not going to think about that room as losing us money, because we could get, Medicare patients there all day long in there with exams. No, we're not going to think about it like that. That's the room for telehealth. That is what it's there for. That is what I can get grants for. That is how I can replace the technology. And we're going to do everything we can, right? Because we can still be an originating site for services as a facility that's using our technology. So WIC counselors, we're starting right now integrating case management, meaning that if you're a part of the Women's, Infant, and Children's program, you could come to our health center, and if you're due for your lead test, we can do that. We can set you up in the room. You can meet with your WIC case manager, and then you can get your WIC vouchers mailed to you, right? So what are we doing? We're saying, okay, we're going to integrate social care. We're going to reduce social determinants of health. So we've reduced cost. We've reduced barriers, transportation, and we've also allowed our patients to be able to meet the requirements of receiving the vouchers without the burden of having to travel so far to get them, right? Parolees can meet with their probation officer. So especially if you're in toxicology screening. So we don't have many, but they can absolutely come in, they can get a urine tox, and they can meet with their probation officer and meet the needs of their conditions, right? Their bail conditions. I see this working bigger in urban settings as well, because I think if you guys did the research and found how many violations of bail conditions were about not meeting with their parole officer on time, and maybe if you dug a little deeper and sort of asked about how many missed sort of appointments were due to transportation, I think you're going to find it's pretty great. Getting there, it's like you got to meet 3 times a week. Getting there is the burden. So I thought, okay, well, this is something we can really push statewide as well, because do we want our parolees to be back in prison and feed them, house them? Or do we want to remove transportation as a barrier and also get a current urine tox screen so that they're meeting the requirements? And so again, we're integrating social care back into a healthcare setting. We're also reducing the social determinants of health, and we're also aligning, or we're sort of in a better, taking a bigger or better step towards value-based medicine. Value-based payment reform. So here's my heart, Department of Health and Human Services. If you're starting this work, I was calling and I was saying, like on the percentage of parents, right? They're in the process of reunification. What does it look like when a parent can't get there? What does it look like when a parent says, well, I don't have the transportation? What does that mean? how much longer do you think did that postpone the reunification process? This is some of the research that you can start thinking about. You don't have to like take my word for it. You can start calling community partners, because parents can meet with their caseworker to increase chances of reunification. If they're coming to your health center, that's closer, right? If they're not having to travel, or even if they can start doing it in their home. And again, if those parents have to pass any sort of urine toxicology screening, they can again do it supervised in our health center. Outreach, right? So housing assistance is done via Zoom, eligibility assistance is being done via Zoom, health educators are being done via Zoom. And I think, again, we're removing the transportation issue and the cost for transportation, but we're also able to sort of integrate that online experience and be able to request control over the screen, which has been very helpful. But then for us, we are limited on space. So our navigators and eligibility assistant workers are able to share space, use headphones, and have private conversations where otherwise having a financial conversation with the patient usually would require being in a separate room. So do you really want every single outreach worker? If you have the space, maybe, but we didn't. So this was better option for us, especially with the parking. We have a parking issue. So all of those enabling encounters can be done by Zoom, and we didn't necessarily have an issue with parking. Next slide. So the benefits, right? The current shift to ultimate payment models led by CMS aligns incentives for the provisions of social care, reducing social determinants of health, right? Increased primary and specialty care, especially in rural health settings. So our referral coordinator has a list now of every single patient, every single specialist that we refer, and there's now another column, telehealth, yes or no. That way, even if our health center wasn't on an island, even where I live right now, to find a pediatric neurologist, well, I went to Boston, but was still an hour and a half away. And not all of the specialist interactions or the consultations, especially for my neurologist, involved the full exam. So that would have been really great to have telehealth and not be able to drive and then spend the night. Increase sort of the relationship too between primary and specialty care services. For example, our patient can come in and we can capture their vitals and they can go in the telehealth room and they could see their cardiologist, right? And before the patient, when the patient leaves, the MA can go back in and say, hey, is there anything that you need right now for Jen Desmond or for so-and-so? So there actually could be a point of care decision made right then, or they can also say, no, but we are gonna have them order, you know, a stress test or this and this, and we can say, okay, what's the diagnosis? And then we're just one step further in the continuity of care process than we would have been with waiting for the document, scanning the document, having the provider review the document, sending the task to the other person. So there's just a little more continuity, well, not just a little more, there's more continuity of care and more transparency in the process. It also is building relationships between the primary care and specialty care providers. Increase social care activities that address health-related social risk factors and social needs. We're increasing continuity of care. We're improving the patient engagement, collaborative partners, and a commitment to health equity. Those are the benefits of leveraging telehealth to integrate social care back into the healthcare system. So let's go to the next slide. So why is telehealth, like Daniel Lauder would say, telehealth is another tool in your toolbox, but sometimes I think it is the best tool to have in your toolbox. Value-based care will require telehealth. I don't care what anybody says, and you don't have to agree with me, but I believe it 100%. I'm gonna stand by that. Telehealth helps increase healthcare value and affordability. Virtual care technology saves patients time and money. Telehealth health visits have a lower no-show rate. That's a fact. There's a bunch of studies on that. 20% of Americans live in rural areas without easy access to specialty services. I actually think it's more. I was being conservative with the data that I was researching. It does improve team-based care for sure, reduces no-show rate again, and may solve staffing shortages. 100% solves staffing shortages for me on my health center on the island. Next slide. Here's all the work cited. So anything that I'm talking about it, you can click on this. This is sort of my my telehealth Bible, my go-to when I'm feeling motivated. I want to think about innovative uses of technology. I always want to be on the cutting edge. And for me, it's like being grassroots and cutting edge. I never thought they would be super married because one seems so linear and structured, and the other's kind of like, hey, you know, we're free thinkers, let's do this. But I'm learning more and more that there is a very good relationship. I think that before, no one believed that IT and quality needed to be married. We know now, 10 years ago, we're like, what? Now we know data, quality, they're married. And I think telehealth is going to be right there with it in that relationship, right? So next. Questions, what do we got?
All right, thank you, Christina. That was an amazing presentation. Jason, do you want to bring up the Q&A?
Absolutely.
And let me just double check to make sure I have given you co-hosts.
It's telling me I can't share right now.
All right, go ahead and try it now.
P1.
Awesome.
All right, so we have one question, and I'll read it out loud for you. How are you managing digital literacy, comfort issues with patients? We're getting questions about payment for different types of navigators, such as third-party services, visiting nurses, navigators at assisted living facilities, etc.
So that was a loaded question. I think, so in the beginning, like I said, we've been kind of doing this for a long time. And in the beginning, it was grant funded, right? So we were starting with the grant funded. So those conversations weren't really necessary for the patient. Then, of course, the reimbursement strategy started to change, and we were able to diversify our revenue by using telehealth services. So we're really clear. During COVID, some of you, maybe it was sort of imposed on patients, right, to use telehealth services because of what was going on with the public health emergency and the pandemic. Maybe during that time, you may have had patients that said, oh, I'm gonna have to pay the same amount. I'm not seeing that as that moves forward because telehealth has now become a choice for them. So there are patients that prefer in-person visits, and there are patients that don't. So when there is a follow-up, we actually have the preference be with the patient, and they understand through multiple conversations, not just the schedulers, not just the front desk staff or the checkout staff, but even the providers are talking about that parity in payment, or you're going to be billed, you know, the same, and they're okay with it. I have so many, we even did in-person conversation surveys about telehealth. And so our strategy has always been to the low-hanging fruit. So we got very great responses on types of visits. So the chronic care follow-up, those were big ones because they're like, when do I have to come in again? I've got to come in already. So the convenience of that being home was great, and they weren't really worried about being charged the same thing. Actually, our mental health population, we didn't know, like, are they going to want that one-on-one? Are they going to want to be seen? And predominantly, they're preferring it too because of autonomy purposes. So we're a small health center. They don't have to walk in and go to their behavioral health specialist, which was a fear that they had right from the beginning. So I'm not seeing anyone complaining, and it's very clear. And even our providers say, you know, are you comfortable having this session in this way? I created an HPI that defaults in on every telehealth visit, and that is for telehealth audio and telehealth audio and video. So I can send you more information, you know, on that later. And as far as the navigators aren't billed separately. It's only their outreach encounters that are being counted. Those enabling encounters, so we don't bill for our enrollment and outreach services. I don't know anybody who does.
Okay, so I'm not seeing any other questions in the Event Mobi app. So just for those of you who missed the announcement earlier before we got started. Please use the EventMobi app to submit your questions. I do see one in the Zoom chat, and I think it's just a very brief one, but Amy Del Bello asked, what did you say was a mandatory read during this time?
Yeah, so it's actually really cool. Can you bring back the slides because we can cut and paste the link?
Okay, Jason, I'm going to go ahead and start sharing my screen
Sure,
again.
or no problem.
I can actually cut and paste it too if you
Okay.
want. I can get it pretty quick. I don't want to get the title wrong. I mean, I'm going to tell you it's integrating social care in healthcare, but it's like really long. Metric right here. All right, it's right at the bottom of slide. Right there. So slide 9. Control C. I'm going to put it in here. Control V. There you go. There's the link. I still go back to it. It talks about the awareness, adjustment, assistance, alignment, advocacy. It also provides a really cool toolkit, incident use cases. I found it super helpful. They're thinking about things, they're outside of the box, some of the recommendations, but simplified planning and implementation strategy. Because I am not a PDSAer. I don't like to talk about things and over. I'm an action person. So I felt like getting from here to here was simplified and I was able to roll it out pretty quickly.
All right, so we have a couple more questions coming in through the EventMobi app. The first one I see is, how could Medicare improve reimbursement for FQHCs? What would you like to see done?
Well, one, they could offer parity in payment, right? So I think that Medicare needs to follow suit. CMS should be following suit. Where we are, I mean, CMS has initiatives out to integrate social care into a healthcare environment. CMS, I have it quoted in here, you're going to see that they're saying that you can't get to value-based without telehealth, right? So they're telling us how to get there and then saying kind of you can't get paid for it, right? For federally qualified health centers, I think it's been at a further disadvantage because CMS is offering parity in payment to fee-for-service providers and not for federally qualified health centers. The problem I have with that is this. We get a global payment, right? So what if we decided to do an office visit and a screening? We're not going to get paid separately like fee-for-service provider would. We're just going to get that $192.03. So we were not favored during this time, but our grants have helped offset it. This is the time, though. This is the movement for advocacy and to push. There is a bill in place right now that seeks parity of payment, which basically is going to be the same exact thing. We're going to get paid the same as we would for an in-person visit. The other thing that I would like to see is reimbursement structure, strategy, program, pilot, collaborative that says, hey, you want us to integrate all this social care. Let's talk about the time, right? We know the value is in there, but are we going to allocate 2 or 3 FTEs? And then how are we going to be, what is the reimbursement strategy going to be? Is it going to be encounters, right? So not just quality measures, but so those encounters, and is that going to say, what if we were 5% down on diabetes, but we had 40,000 enabling encounters? Can that lift us to a place where that value-based payment, we're now there? So that's what I would like to see, some give and take with that in that model.
Okay, next question asks, are you doing screening for digital access / literacy as part of other SDOH screenings? And if you already answered that, you can ignore it.
No, that's okay. So we do the social determinants of health screening. We were using Prepare, but Prepare was so big. And I'm using NextGen as a vendor, and NextGen has an excellent SDOH tool that also auto-populates the DAST based on questions. It will also take me to the audit screening. So we are screening there. So here's the thing with those screenings, right? It's not the social determinants of health screening that gets you sort of the payment. It's where it's leading to, right? So a part of that, if it's leading to the PHQ-9, I'm billing for that. If it's leaning like towards like the expert screening, then I'm billing the 99408 and 99409s, right? If it's leaning towards the PHQ-9, then of course I am doing the GO444 for Medicare and such. So you can do these screenings via telehealth for social determinants of health, but it's what's coming from that that's being billed.
Okay, this next question is a little bit long, so what advice do you have to FQHCs who have never developed infrastructure for telehealth? Due to COVID, they use consumer devices and applications, got frustrated because patients didn't have adequate bandwidth or have video-enabled devices. Now these patients are going back to in-person and staff are abandoning telehealth.
Okay. So we should never abandon telehealth for patients that don't have broadband issues, that prefer it. So I think the reason why we do so well with it is because we looked at what was working. So for example, provider buy-in. Right now we're talking about our post-COVID schedule, which will be like telehealth in person, telehealth in person, telehealth in person. So before, some of the concerns that I would have, and this is with provider retention and recruitment. When we think of our mental health population, we think of our mental health providers, right? But I can tell you, if you did the work, your largest mental health population sits with your primary care providers. Otherwise, it would mean that if you had 60% mental health population, that they were, you had at least 40% seeing your behavioral health providers, and I haven't seen that anywhere. If you have, that's amazing. And so one of the things that they would talk about was how their visits were sort of hijacked, right? So it could be that they have a patient that comes in for, their ankle is a sprained ankle, but then all of a sudden they're just talking about depression, right? And you can't really leave and you can't really focus and you're kind of worried about your next patient. So what we've done for the providers, if it's a patient preference, is we've gone ahead and our providers are preferring to have those visits. Our behavioral health too, for the most part, except our school-based health. So school-based health, it doesn't work unless the kids are older, because they love all that technology. But for the school-based health kids, our behavioral health providers like to play outside, do creative play, shoot baskets. So is telehealth the tool in the toolbox? No. In-person visits are. And I think that's where you have to start. It shouldn't be an all or nothing. It shouldn't be something that's forced. It should absolutely be that the value is the same. I would attack your no-show rate first. I would then go to anybody who identifies transportation as a barrier. And then we can talk about if there's also a barrier as far as audio, video, telephone only, because everybody other than Medicare, you could do telephone only. So that would be my strategy. I would start with the winners. Don't abandon it all the way, but also don't force it. I don't like well-child visits via telehealth. I don't like physical exams. Physical exam means let's get physical. I don't want that. I don't want to have to worry about capturing vitals later. I want to do what works. And I want to do where I want to know that that value is the same no matter what.
Okay, so let's give it a minute. I don't see any new questions in the feed. I see someone is trying to raise their hand, but they've put it back down. We do have ample time. I think this could be a good opportunity to have some of you in the audience. If you wanted to ask your question verbally, we do have that option for you. Just raise your hand. Should be in the participants option. Okay, there we go. So I'm going to go ahead and let this participant talk. Daniel, you're live. We can hear you. We should be able to hear you.
Oh, he's muted.
Yeah, let me see if I can unmute him. I cannot.
Did it?
There we are.
Better?
There you go. We can hear you now.
Thank you. I'm Dan Halpermuter. I'm down here in Ireland. And it occurred to me that there's really a whole new area of expertise, which is the transition from procedure-based to value-based healthcare. I think a lot of people look at it as a solid line, and that you one day you're doing procedure-based, and the next day you're doing value-based, and life doesn't work like that. And so so what, the totality of what you said is that we are integrating this in little by little, because we know that the payday will be that when we go to value-based, we'll be champs at that, and we will be able to retain resources like nobody's business.
That's right.
So that's I'm wondering whether certainly I'm sure there's an association of FQHC people, managers, and I'm wondering if that's not a topic in and of its own, as to how to segue from one to the other.
Well, I think you're right. I think it's always been how to segue from fee-for-service to value-based, right? And so I have decided that I'm going to do that instead of, I'm sort of hearing the same webinars. I don't know if you're attending them, and it feels really rigid, right? And it doesn't feel very fluid. It feels like you got to get there, and there's a 3-year, and there's downside risk, and you got to be here. But at the bottom line, value-based is this. If you don't meet the quality measures that have been outlined, you are not going to get the same reimbursement, right? And so one, we're going to have to battle with and advocate of whether the numbers that they're saying are taking into consideration social determinants of health and health disparities, right? And then if we're integrating social care into the healthcare setting, are we getting credit for that? Because there is value in that. And so my argument to sort of this structured, I still don't understand it. I've been doing this since I've been 16 years old. I don't understand where all of these discussions are coming from. They're going to tell us we need to be here. We're not going to be here. How do we get there, right? And the strategy that I'm going to have is that I'm going to integrate social care slowly into the healthcare setting. And I'm also, my preferable tool to do so is going to be using telehealth and population health. Population health and telehealth is going to be the way that I think I can get there. Now, I think that the winner is going to be patient engagement and preference. If a patient said to us, oh, I'd rather just come in person, we say, sure, come on in. And we think that's perfectly fine, and it is fine. But what I don't want is a patient not to show up when they need to be seen because of a transportation issue or because of a childcare issue, right? We have another tool in our toolbox that we can offer so that we can create additional access. And this is the same for specialty care. Like our primary care providers, we need to start talking to our specialists more. We need to start, increasing access more. We need to start pushing telehealth as an option for them as well. And if they say, well, I'm going to need the vitals, well, we're going to do it, right? I'm going to need the current blood pressure. We got it. They're not getting paid anymore to take vitals. We're not taking away their revenue stream, because those patients are being seen in their office. It's not attrition. So we're going to have to do this work.
Okay, so Daniel, I'm gonna, sorry, go ahead, Christina, did you have something else?
I'll let you
Thank you so much.
Okay.
Thank you, Daniel.
Christina. Thank you, Christina.
Okay, thanks, Daniel. I'm gonna disable your audio now. So we have a question in the Zoom chat. We have tried to build a tobacco cessation to commercial payers. However, most all went toward their deductible and the patients were getting upset. Do you have any opinions on how to handle this?
Well, first I would like to ask if when you were doing tobacco cessation in person, were they getting upset? Or are they just getting upset because they don't think that there's value in having the tobacco cessation counseling?
They responded yes.
So yes, they were still getting upset when you were doing it in person? Yes. Yeah. Well, then it's not a telehealth issue, right? They're either going to get, so tobacco cessation counseling, they're getting upset whether you're billing for it in person or telehealth. So now let's talk about the different strategy, right? So they didn't find the value in tobacco cessation counseling. So I understand that. So if you have a smoker, they're identified as a smoker, right? If I was identified as a patient with depression, right? I get to go see a behavioral health counselor, I know that I'm being billed for that. When you're sitting in the room with your primary care provider and they're like, are you a smoker? Yes. And then the provider immediately starts going into tobacco cessation counseling, it's sort of being done to them. Why do they have to pay for it, right? So we don't do that. If it's a smoker, just say, we actually say, I'd like to provide you with tobacco cessation counseling. Like, we have those conversations. Or would you like our care manager to reach out? And if they say that would be great, then our care manager provides the tobacco cessation counseling, and it's billable. So again, it's like when I say I go to the hospital and I get charged a million things, and I don't like it, it's going to be the same for them. So I think these are conversational pieces. Just because there's a smoker doesn't mean that patient wants tobacco cessation counseling. And they shouldn't have to pay for something they didn't ask for, just like we don't want them to. But again, you can get around that with conversations, which I think that could be a whole other session, right? Some of those scripting and how we can talk about that. That would be a really, really good conversation, because I've said a lot of things and it's worked, so.
Okay, so we have another question in the EventMobi app. What other services would you like to offer via telehealth? What other telehealth technology would you like to try out?
Oh gosh, so I can tell you what we've done. So we've used telehealth to connect with emergency providers. That was more of a convenience and quick than it was a billing strategy. Like, we have urgent and emergent services, and sometimes they're going back and forth and sending pictures, and we're not even thinking about reimbursement. We just need somebody to answer us on the phone. So telehealth is the umbrella. Again, it's so confusing right now because telehealth now is telecommunications, right? And then telemed is now telehealth. So telecommunication strategies, what we're doing, or what I want to do. I want to do remote patient monitoring, but I'm probably going to struggle with that because we only have 8% of our patients that I shouldn't even say use the portal, that signed up for the portal. So I haven't spent a lot of time. It wasn't a low-hanging fruit. So, but I would like to do that. I would like to do remote patient monitoring. I'd like to have all of the blood pressure, glucose monitoring, all of the devices integrated via telehealth. What else would I like to do via telehealth? We're doing kind of a lot. I mean, we're pretty much doing everything other than physical exams, well child checks, procedures like wound care and stuff like that. So.
Okay, so it looks like Daniel's going to raise his hand again. I'm going to go ahead and allow him to talk, use his audio. Daniel, you should be live.
Okay. Can you hear me?
Yep.
Yep, we can hear you.
So the difficulty in terminology is substantial. Is substantial in what you're calling telehealth. I like to call it e-health.
Yes.
And then say, okay, a big part of e-health is telehealth, which telehealth is mostly educational. And then there's telemedicine, which is clinical. And then you can look at mobile health, which is both clinical and educational. And so that I find very convenient because my mind requires little harbors, and that does that for me.
Yeah. Well, CMS changed sort of the definition on us, and that was a little bit difficult. And I guess I can understand, before telehealth was the umbrella and telemedicine replaced the in-person visit. But I think now that there's telepsych, teletherapy, teledentistry, this, you know what I mean? I think that is why when the public health emergency shifted, they started changing their definition. But if you look at some of the state plans are still saying telehealth is up here as the umbrella, even if you Google the definition of telehealth. But I think you're on to something with e-health. I like to just say innovative uses of technology. We use innovative uses of technology. I've been using that as the terminology, but what I'm seeing now, what's coming, what's fresh is telecommunication, using telecommunication as a method of delivering telehealth and e-visits, which is long and winded, but we have to get it down because it's confusing for sure. And that was part of the biggest problem with the public health emergency, was that telemed and telehealth meant the same thing to them. And that virtual communication services, part of their definition, CMS's definition, was also a telephone E&M definition. And so that was a little bit difficult because, like I said, the terminology and what they mean are changing. So that would be a really good national strategy, really. E-health is great. I think that's perfect. Provide e-health services in one way or another, and then we can talk about the reimbursement for each one of those.
Yeah, it's not my, I don't want to take credit for inventing e-health. I just think it's the right, it has the right sound.
It just makes sense. Yeah, as soon as you said it, who could argue, right?
No, somebody can always argue. Thank you so much.
Thank you. I appreciate it.
All right, thank you, Daniel. Okay, so I think we're clear. I'm not seeing any questions come through the feed or in the Zoom chat. So I guess we can end a little bit early. Yeah, so I'm not seeing any questions. Okay, so thank you everyone for joining us today on today's session. Just a friendly reminder to please fill out the session feedback form. When you navigate your way back to the Event Mobi app, you should be able to scroll down, and at the bottom there's a session feedback button. Please fill that out. We do appreciate your comments. And thank you everyone for joining us today. I hope you all enjoy the rest of the conference. And thank you, Christina, for presenting.
Thank you. Any questions, send them along. I'm super good at email responses. So anything else you think about later, just let me know. Thank you guys. I appreciate it.
Perfect. Thanks everyone.